And joining us now on the debate in St. John's, Newfoundland and Labrador, Roger McIntyre, head of the Mood Disorders Psychopharmacology Unit at the University Health Network. And with us here in studio, Norman Doidge, psychiatrist and author of The Brain That Changes Itself, and Ian McGilchrist, psychiatrist and author of The Master and His Emissary, The Divided Brain and the Making of the Western World. I want to start by just sharing with you and our viewers a couple of, I think, important facts to bring to this discussion, and then we'll go from there. Michael, if you would, let's bring these up here. 1 in 5 Canadians will experience a mental illness at some point in their life. Schizophrenia affects 1%, major depression afflicts 8% of Canadians, and 12% of people suffer from anxiety disorders. That's from CAMH, the Centre for Addiction and Mental Health. Those are relatively new numbers. Roger, let's get it started with you, please. There are those who peg the number of people who experience mental illness as being closer to 1 in 4 or even 1 in 3, not 1 in 5, as CAMH suggests. Tell me this, are modern societies producing more mental illnesses than psychiatrists know how to cure?
Well, the question about whether modern societies are producing more mental illness, I think, is really the nub of the issue. And there has been reports from some countries and some regions that the rates of mental illness are on the way up. I think we do have, however, some conflicting evidence. And the way to look at this methodologically, Steve, is you'd want to look at really a longitudinal study. That'd be the ideal way to do it. All things created equal, look at a cohort over multiple decades of follow-up. And as you would expect, that type of effort is very difficult. It's costly, and those types of studies are rare, but they do exist. In fact, one of the studies here in Canada, Stirling County study, named after the Digby County in the southwest corner of Nova Scotia, in fact, is a 60-year longitudinal cohort. And in that study, when they looked at a host of mental disorders, what they found was that the overall rate of depression, one of the topics of focus for today, in fact, did not change at all. It remained pretty consistent, actually, at about 5 to 6% over the last 5 to 6 decades. What's important to highlight, though, is if you look at the overall population, you may miss some of the detail. And that is in some of the subpopulations, those who are perhaps consequenced by some of the social deterioration, whether that be to unemployment, to crime, to lack of religiosity or decreased religiosity, decreased affiliation with family, marital and family breakup, those subgroups had increases in their rates of mental disorders. So I think what to come up with a sort of a broad statement, mental illness is on the way up, it's certainly conflicting in terms of the results, and I don't think all organizations would agree with that, but I think there's plenty of evidence to say that there are subpopulations where there's an increase, and there may be cultural or certainly time-related factors where this hits home. For me, the best example is what's occurring in the United States currently. Last year in the United States of America, there were more veterans who committed suicide than died in combat in Iraq and Afghanistan combined. And that's quite a statement, non-specific, but a powerful statement about the mental health of those individuals returning from combat. So again, this obviously is a very high-risk group, but I think there's many lessons for us to learn from these high-risk groups. So I think a general statement difficult to support with empirical evidence, but there's many examples where subgroups have higher risk.
Let me just get Norman to pick up on that last point there. That is a shocking and tragic statistic, that there are more vets dying of suicide, dying of their own hand, than would have died overseas fighting in those wars. What do you infer from that?
Well, modern warfare is in some respects much more intense than ancient warfare. It's much more prolonged. Famous battles between Athenians and Spartans lasted a number of hours. Modern warfare, when it's unfolding, is just unremitting. And then perhaps people are witnessing more trauma, in part because of our equipment protects people from dying, but they see some pretty terrible things. There's a lot of brain trauma mixed in there with the post-traumatic stress disorder. And then, I think it's pretty fair to say that we have not done as well as we should for our veterans who return home.
Who's we?
Well, if you look at, the health care for veterans, it's not always the finest health care. I don't know what to say about it.
Do you mean psychiatrically? Do you mean in terms of their physical condition? Do you mean in terms of, I presume you mean everything, getting them jobs when they come back, the whole 9 yards?
Yeah,
Okay.
I mean, I think we owe it to them to really do our very, very best to help them deal with it. And, you know, we've been, I mean, now, of course, there's a lot of attention being paid to PTSD. Post-traumatic stress disorder. But I also think that we've been somewhat slow to try some of the new treatments that we have with veterans, which are pretty helpful for PTSD as well.
Yeah, let me go back to that original statistic that we put up there, which was 1 in 5 Canadians experiencing mental health issues at some point in their life, and others suggesting it's closer to 1 in 4 or 1 in 3.
Yeah.
Where are you on that scale?
Well, I think Roger is exactly right to say that this is a vexed area, and I think nobody can say with confidence that they can give you a clear answer on this, because there are so many confounding factors. There's, you know, a greater awareness of these things, fashions of diagnosis, people are less stigmatized by admitting to mental illness, so they're more likely to come forward for help. We operationalize diagnoses, so we end up getting people ticking boxes and scoring as having an illness that no psychiatrist would diagnose them as having. There are pressures on people to have a diagnosis for reasons of litigation or to get hands-on resources. There are all sorts of pressures that skew this. And so it's difficult to be absolute about that. But I think what Roger was hinting at was that when there is he called them subgroups of people who are divorced or alienated from family or don't have a church or so on. I don't know what, I'm not, this is my first visit to Canada, but in England those would not necessarily be subgroups. They would be very large chunks of society.
Very mainstream, isn't it?
And there are a lot of pressures on people that make them very unhappy. And if you have a fundamental lack of, if you're not grounded with a very good self-esteem, then you can easily be derailed and sent into states of anxiety and depression. And I think it just depends what you mean by these terms, and I think we'd all agree that round this table. You can't be adamant about what the level of depression or anxiety is, because it has fuzzy edges. But I think, you know, I would caution against dismissing the idea that these things are on the increase. My experience of older people I live in a rather remote part of the country where there's a slightly more of an old community structure to things. And my impression is that the rates of mental illness are higher amongst the younger people than they were amongst the older people.
Norman, might have been 2 or 3 visits ago that we had you come into the studio to talk about your book on the plasticity of the brain and how the brain changes itself. Can you help us understand how the plasticity in the brain, the constant changing of the brain and how it changes itself, how that helps us understand mental illnesses in the brain?
Sure. You know, plasticity is the property of the brain that allows mental experience to change brain structure and function. And as it first came to light, we were focused on how it can help people get over certain illnesses through certain kinds of focused mental experience. But a changing brain is also, in some respects, a more vulnerable brain to all the mental experiences we have. So what it means is culture can actually alter the brain, and not always for the better.
Culture meaning what?
Well, last evening at Ian's wonderful lecture, we were talking, amongst other things, about digital culture, and a teacher got up, and she worked at the nursery level, and she said this thing which, it's going to sound exaggerated, I know, but she said that she's finding that kids who are coming to nursery in increasing numbers are not good at looking at or reading faces. Now, this is a right hemisphere function.
It is indeed.
And of course, you could write that off as an anecdote, but Ian's had been told about that thing happening all the time. And, you know, people are increasingly, at very, very early ages, going online and looking. I do it with my grandchild, you know, looking at people on Skype, etc.
And that's an explanation for it, you think?
Well, that might just be one example. Look, the key example, I think, is the alteration of our attention spans, particularly for sustained attention.
Exactly.
And that's being driven by the digital age. Another thing that the digital age is driving, I mean, people are, I think, are much more wired because you have this connectivity that's going on 24/7, which means that there's lots and lots of stimulation people are having. Of course, there are many more demands on people at work to be constantly processing tons of things. And this turns on the sympathetic nervous system, the fight or flight reaction, and increasingly people don't know how to turn it off. They're not returning to normal downtimes. And not only is there more time spent connected, but of course we're connected to remote events, and therefore we hear about a lot of terrible events. And I think people are walking around in a much more wired condition. And that's one of the reasons people are interested in turning to various things of the East and meditation, because it's a groping attempt to come to terms with this. People are also, to some degree, in the information society, often imprisoned in a cubicle. It's not even a cubicle anymore. It's like the 18 inches between you and your computer. And the sedentary lifestyle is making people feel very trapped. It's very bad for the heart and the brain.
I want to get Roger's take on this. Roger, you've heard what Norman has to say about whether this wiring, if I can use that word, into the various machines of our culture is affecting our mental health. What do you think?
Well, a couple of points there. Let me just pick up on what Norman was saying. I think the plasticity argument is well supported. I think Norman has very much communicated this very clearly in his book, and I think Ian also, I suspect, belongs to a camp that would be in belief of the literature on that. And so one of the sort of favorite sort of dinner table or dinner party examples is the taxi cab drivers in London having larger areas of the brain that are for spatial memory and so on. But let me just pick up on this issue of circuits. And it's something that has been curious to us in psychiatry for a long time. It's important to highlight that in psychiatry and neuroscience today, we have over 20,000 reports that have used neuroimaging methodology in the last 2 decades to look at the brain under both normal and abnormal circumstances. And what's interesting is that intuitively, when you think about the brain at rest, when we're awake but at rest, not involved in any kind of task, we would intuit that the brain's really in a kind of a quiet mode, in contradistinction to when we're asked to do a cognitive task or emotional task or a motoric task, where you would expect that it's extremely busy. Well, the reality is that when the brain is in a state of wakefulness, but in quotes at rest, it's actually very, very active. And what's interesting is that the regions of the brain that are very, very active when we're in that quiet state, what William James would have called the stream of consciousness, the inner voice, the inner self, that mind-wandering part where we find our transitional creativity, those brain regions light up when we're in that sort of state of quietness. And they're very, very active. So, and just to go forward with that, if I could, that region is known as the default mode network, the DMN. And many people in the world of neuroscience and cognitive neuroscience now believe that has relevance to both normal and abnormal human functioning. Here's a wonderful example. We now know that if I ask somebody to think about themselves in the context of themselves, or we make reference to them, or we show them pictures of themselves, this default mode network lights up. So it lights up when we provoke them, but it lights up when they're in this state of sort of quiet, sort of self-reflection. What's interesting is that victims of trauma, of physical and sexual abuse during childhood, a very common complaint to me as a psychiatrist is they feel a sense of inner emptiness, a loss of self, a sense of void. And what's interesting is that the default mode network in these individuals is decreased in its activity. I guess the point I'm trying to get across here is that there's no question that the external environment is becoming noisier, faster, and more distractible. But I think we've probably underestimated how active the brain really is when it's in a state of quiet wakefulness. And we're now beginning to learn that these circuits that subserve this experience may be relevant to both normal human function as well as abnormal circumstances like the mental disorders I mentioned.
Understood. Let me take this moment to play some tape. We want to talk about antidepressants. which people take, of course, when they're suffering from mental illness. 60 Minutes, the American television program, did a piece on this recently, and well, we're going to show a little clip here from a piece they did on whether antidepressants actually work. Roll tape, Michael.
So when you did your study, you put all the trials together.
That's right.
You're looking at patients who took the real drug and patients who took the placebo.
Yes.
Did they get equally better? Or did the ones who took the pills get even a little better?
If they were mildly or moderately depressed, you don't see any real difference at all. The only place where you get a clinically meaningful difference is at these very extreme levels of depression.
Now look, psychiatrists say the drug works.
Right.
The drug companies and their scientists say the drug works. Maybe you're wrong.
Maybe. I'd add to that, by the way, patients say the drugs
Patients say the drug
work.
works.
And for the patients and the psychiatrists, it's clear why they would say the drug works. They take the drug, they get better. Our data show that as well.
You're just saying why they get better.
That's right, and the reason they get better is not because of the chemicals in the drug. The difference between drug and placebo is very, very small, and in half the studies, non-existent.
Okay, Ian, to you first. That's obviously a hugely controversial thing to say, which caused a lot of attention.
Yeah.
It suggests, of course, that you, the drug companies, that a whole range of people have no clue about what makes antidepressants work.
Well, the first thing to say is that it behoves us all to be skeptical of the data put out by pharmaceutical companies, and I'm afraid that they don't have a very fine track record of honesty and openness. So I completely understand that, but I'm afraid this is a very crude message. And it's typical of what you get when you aggregate millions of bits of data. You get a fluffy answer that nothing really shows up as significant. But actually, to anybody who has experience of treating people with depression, or as I myself have, both of treating people and of suffering from it, I wouldn't buy this story for a minute.
Let's just, you went by that rather quickly, and I want people just to note, you don't just have clinical experience on this, you yourself suffered from depression many years ago.
Most of my adult life.
Most of your adult life, okay.
And I know very, very well the relationship between taking that medication and getting better. And my first experience of it was actually so dramatic for me. It so completely took me back to a way I hadn't been for years, that it was one of the things, apart from, there were many strands to why I moved from my previous world of lecturing in the humanities to wanting to be a doctor and a psychiatrist, but it was one of the things that impelled me to do so.
Because it worked?
Because it seemed so important, and to be able to do that for other people seemed a very important thing to be able to do.
Norman, can I get you to comment on this notion that psychiatrists, pharmacologists, big pharma don't really understand the nature of depression very well, as Irving Kersh suggested, and that most of the stuff works just as well with placebo as with the real thing?
Well, there's many things in there. As for the understanding of depression, the emphasis for the last number of years has been focusing on particular chemical messengers called neurotransmitters. And one of the things that's happened is about every 7 to 10 years, there's been an alteration in the explanation as to which neurotransmitter is decisive. When I started practice and when Ian started practice, we used drugs that were called dirty drugs because they hit a lot of neurotransmitters. Then they were replaced by ones that focused on serotonin, and then they were replaced by ones that focused on other neurotransmitters. Now, the explanation keeps changing. I do think it's fair to say that whatever depression is, it's much more complicated than someone saying it's an absence of a particular neurotransmitter. Because there's a circuitry question. In Toronto, there was very important research that showed there's a certain circuit in the brain around an area called C25 that in intractable depressions, if you stimulate it or if you give it a certain kind of electrical stimulation.
Where is that?
Roger, where would you singulate?
How would you want to describe where C25 is?
Well, the cingulate cortex would be a region in the so-called limbic or the subcortical region,
Yeah.
and it's part of a larger circuit that subserves emotional processing and integrating with cognition.
Okay.
I mean, I'd illustrate it this way. If this is the brain's, if this is the spinal cord, and this is the emotional part of the brain, the cerebral cortex wraps around it like this. So it's kind of deep in the brain, like that.
And if you stimulate that C25,
In some people, in many people with intractable depression, it actually can lift spontaneously. So there's a circuitry component to depression, and then of course there's something that's going on inside in your life that's a component of it. So there's been a message out there that's been very reductionistic, and so some people are reacting to that, and it also turns out that the circuitry for depression is also related to the circuitry for common unhappiness in some respects. So, depression's also about demoralization, but it seems that in some people, at a certain point, it's like a switch is triggered, and then you lock into that, and you just cannot get out of that, and that's the crucial thing. And I mean, I've used medication with patients, and from time to time I've seen the kinds of things that Ian has described. But one thing should be noted about Kirsch. Kirsch is a placebo researcher, and he stumbled upon two really important things that we have to face in psychiatry. The first one is that there were certain changes in how the FDA goes about approving drugs, and he discovered that about 40% of drug trials had basically been suppressed from the public. And because it turns out that those were the trials that showed that medication was not working better than placebo.
I see.
So this is huge.
Yeah.
And for I want to be able to say to patients when I think they need medication that there isn't this kind of scandal in behind. So there's a need for real transparency about this.
Absolutely.
And I'm a doctor, I work for my patient, I don't work for the drug companies. The drug companies have come up with some really important inventions, but one thing that Kirsch has found, and this is something that we really have to think through, is while people can sort of differ about how much better antidepressants are than placebos for depression, placebo rates are pretty high in depression. What happens in a placebo reaction is you expect that you'll get better because the culture and the doctor tells you this pill will work. And so placebo reactions don't just work when you get a sugar pill, they're also working when you get any other kind of intervention. They're working when you get psychotherapy, they're working when you get a medication and your doctor says, I think this will help you.
Because you're expecting that it will.
Yeah, and this is a neuroplastic phenomenon to some degree, right? Because your mental set is somehow triggering certain circuitry. So we've spent billions on investigating drugs. How about throwing a few billion to investigate the placebo, which is making a big contribution to being, it's a way of turning on a circuit.
I'd agree with that. I think the really interesting thing here is how powerful a drug placebo is, and that actually lacks an explanation. We have all sorts of hypotheses about how that actually comes about, but it's a fascinating instance of mind interacting with matter. But I just wanted to say I agree wholeheartedly with Norman that the mind and the brain are wondrously complex things. Of course there are circuits, there are chemicals, there's more connections in the brain than there are known particles in the universe. You can't reduce a human experience to a chemical, but that is to use that as an argument, and I know Norman is not, but if people think that's any kind of an argument against using an antidepressant, it doesn't get off the starting blocks, because it just is true that certain drugs are able to alter mood, and we don't have any problem in saying that uppers and amphetamines and LSD and E and various other things alter mood. They do. Why should we be so rooted in our objections to the idea that certain marketed chemicals do? But I want to reinforce also that we need much greater transparency and much greater honesty and openness from the pharmaceutical industry.
Roger, I hear you trying to get in.
Yeah, I want to pick up on this. I think this has become such a significant issue in the conversation in psychiatry, and I want to just to touch on a few points. I agree that there has been, I think, a larger discussion around transparency. I agree with Ian on that. I don't think we've actually seen all the data we would like to have seen, and there's been sort of efforts to try and uncover some of this data. I think it's cast a certain mistrust throughout the entire field, and it's had, in my view, a very significant and negative effect. We've seen, for example, a decreased use of antidepressants in younger populations, in kids, for example, in the United States, Canada, and the UK, and that's been associated with an increase in suicide in kids. I call that a deplorable outcome. Now let me in fact just respond specifically to this, because I think that the public has been perplexed. First, there is in fact no such thing as a single type of depression. Depression is probably a final common pathway of many different etiologies and many different causative factors. So just like an infectious disease or like diabetes or cardiovascular disease, there's not going to be one medication or one intervention that's going to be the panacea, the solution. The second point is that just because a medication mitigates the symptoms doesn't mean that the underlying pathoetiology is the opposite of that. In other words, if Tylenol remedies your headache wasn't due to a Tylenol deficiency. So these things don't have to be so linear. The final point along that line is as follows. Going forward, what we have not done and what we're going to do in the field is what's already occurred in other areas like infectious and parasitic diseases. And that is that what we need to understand is the biological basis, that is the so-called biosignature of these conditions. And if we have a more comprehensive, more fuller understanding of what is the underlying biology to these conditions, and I'm going to broaden that to the psychosocial biology of these conditions, then that will position us, I think, in a more strategic way to say, well, this treatment you should get, and that treatment you should not get.
I don't think that's likely to happen, Roger, because as you rightly say, depression is as various as humanity. There are so many different kinds of depression. And this is why I find government guidelines that I'm helpfully given about how to treat depression really are quite by the by, because every single person that comes to me is going to need a different approach. And I suppose one of the problems with these aggregating studies is that you know that certain treatments, including certain antidepressants, won't work with certain people, and you may try them, and you have to try 2 or 3 before you find the one that does work. Now, if you aggregate all those studies, it seems like they don't work very well. But one drug for a certain person works extremely well, and another for another person works extremely well. So that information, which is at the individual, the unique level at which a clinician is operating, gets lost in these studies.
Well, and that's a key point. So there's not going to be one single factor that's going to say, well, because you have this feature of depression or you have a family history, that's going to say you're going to respond to treatment X or not respond to treatment Y. And there's other areas of medicine where this is also played out, oncology and so on, where the reality is we're going to need several factors, several factors that together in a combinatorial equation increase the probability. They don't guarantee, but increase the probability that you will in fact have a desirable outcome.
Yeah, indeed.
And as opposed to the current status quo, where admittedly we're just simply treating things empirically, we don't have any way to guide our treatment.
Well, I just wanted to emphasize this whole issue of guidelines that are drafted out of context as algorithms is, and aspects of evidence-based medicine, which many people think is the answer to our woe, is a great example of how left brain, a left brain tendency is trying to, it takes a process that at this point, just because of the level of our knowledge, requires subtlety and a certain degree of art at this point, and sort of box it in. And it's actually really, really problematic, and it has to do with how we train residents too. And so when you get somebody who's experienced, like Dr. McGilchrist, and he's dealing with a patient, he is looking at it, I believe, in a more right-brained, holistic way. And I want to raise in that context the role of psychotherapy, because one of the things that happened is, once upon a time, psychotherapy and maybe electroconvulsive therapy were the major things we had to offer patients. And then as medications became more and more popular, there was a tendency to shift the giving of medication to primary care physicians who have 5, 10, 15 minutes to see patients, and psychotherapy got left out of the equation. And people were increasingly starting to report that depression, which was once, when I was in training, treated as often an episodic illness that lasted from 6 months to 12 months, that's how long you'd use an antidepressant, was increasingly being described as a chronic disease. And that coincided with, it seems to me, giving out antidepressants in the absence of what I think is proper care, which would include psychotherapy, because it's pretty traumatic to experience a depression. And so I really think that we have to really go back to this combined approach and use both the mental and the physical, and understand that something like psychotherapy is a biological intervention insofar as it uses mental activity to also modify brain structure. One's more top-down, one's more bottom-up.
Yeah.
Well, let's talk resources here for a second then. Roger, to you first here. In Canada, if I've got the statistics right, there is one psychiatrist for every 8,000 Canadians. In some poorer countries in the world, that ratio is one psychiatrist for every 2 million citizens. Should a country like Canada have more psychiatrists?
Well, I think when you look at what's considered an ideal ratio, certainly the ratios we have in Canada, we'd always like to see more. But I think, you know, if I could just pick up on that number, if you look at the province of Ontario, and you look at, you know, that's where, you know, certainly the majority of psychiatrists are in the province of Ontario. When you actually look at the practice pattern of psychiatrists, and this has been looked at now for a while, and there's been some recent data now here in Ontario, that psychiatrists, even the newly graduated psychiatrists, tend to fill their practices very quickly. And there tends to be an overrepresentation of patients that they see on a high frequency. That is, they're offering ongoing treatment to. Now, there's going to be differences of opinion on this, frankly, but I don't think we're ever going to have enough psychiatrists in Canada. When you look at the prevalence rate of mental illness in Canada, if you take 4,000 psychiatrists in Canada and you multiply that by 40 hours a week, you're at 160,000 hours in a year. We've got almost 1 million people with mental illness in the country. So I think that the whole model of healthcare delivery needs to be looked at. We've not got enough psychiatrists, and I think there's been really not just lip service, but I think there's been examples where collaborative models working with allied health professionals, particularly in primary care, where the psychiatrist clearly serves as someone who is an expert in the area of mental health and mental disorders, but works more collaboratively in the delivery of that care. It's just not feasible, given the number of psychiatrists we have, the number of hours in a week, for psychiatrists to really take on all these individuals. Moreover, the current practice pattern is one where things are not going to change anytime soon.
Well, let me go to Ian on that one. You know, they say when you want to alleviate traffic congestion, you build more highways. But in effect, you know, they get congested just as quickly, and what you've just done is created more traffic. Is it the same thing with psychiatrists? If we doubled the number of psychiatrists tomorrow, would we suddenly be seeing lots more people coming forward with mental illnesses, and we wouldn't be any further along, actually?
Well, we'd be further along because they'd be getting treated. There's definitely an undersupply, and it's very marked in Britain. The National Health Service, which I think is a wonderful institution, is completely overwhelmed by the need for mental health services and finds it hard to provide ongoing treatment for people. It tends to focus on the most severely mentally ill. They have to be prioritized, that's absolutely right. But there's a tendency to think of other people who may have absolutely life-crippling ongoing illnesses of anxiety, depression or addiction as somehow they'll just have to get by with whatever the GP gives them. And so, no, we desperately need more psychiatrists. It's not a situation in which we can afford to allow things to go, if I'm right that people are suffering more than they used to. In
which case, just a few minutes left here. Norman, if you could wave that magic wand over the Ministry of Health's budget here in Ontario, $47 billion budget, not all of it obviously for mental health, but how would you reallocate existing spending? Because we know we're not going to spend more going forward. How would you reallocate the way spending?
I'm not an expert in that. I think we could use some more psychiatrists. I wouldn't want to see psychiatrists just become people who do assessments and maybe prescribe medication only and become separate from the mind. I mean, I think another area that might be helpful in the long haul would be where plasticity might offer some assistance is, look, the model, and Ian has shown this, I've talked about this a lot, the model that people have had of the brain is seen it as a machine. And you would come to the psychiatrist and with a broken machine. And the psychiatrist's job is to fix it. And the patient actually, to some degree, is left out of the process. The patient is put into a passive process. But now that we know that mental experience is very much involved in changing brain structure, I think what we have to focus our attention on is ways, and some of these things can be done in groups too. Like Ian and I have both had wonderful experience for patients where
some of these things can be done better actually in groups.
yes, where meditation is involved for maintaining people for depression and so on, where the patient's brought more actively into their own treatment. I think that as we develop those techniques, and that's with brain exercises, that's with, but I really think for psychiatry to remain humane and in touch with what we do, we need a number of people who aren't just managers, but are like the psychiatrist you would want to go to if you had a problem.
Steve?
I'm down to, Roger, I'm down to my last minute here, so go ahead.
Yeah, I think the other sort of, it's more of a, at this point, a conceptual issue, Steve, but something I think we should reify and concretize and make as an action plan in the field of psychiatry. We spend too much time on treating mental illness. We don't spend any time talking about preventing mental illness. And we're not going to have enough psychiatrists in Canada, full stop. We're not going to have it. And so we need to accept that reality. And every area of medicine, they talk about prevention, except in psychiatry. There's already examples where, for example, women leaving hospitals with newborn babies at risk of depression, rates of 10% of postpartum depression. If we visit them within 4 weeks of leaving the hospital with careful screening for depression, we can actually reduce some of the burden of depression. The implications for mom and the baby are enormous. So I think conceptually we need to move into prevention. That's the strategic direction to deal with this serious problem of mental illness.
We got to do that across every discipline in healthcare, quite frankly. But anyway, so much for that editorial comment. Thanks, everybody, so much for joining us tonight for this very important discussion. Roger McIntyre, the psychiatry and pharmacology guy at the University of Toronto, thanks for being there for us on the Rock from St. John's, Newfoundland and Labrador.
Thank you.
Norman Doidge, the psychiatrist here in Toronto, author of The Brain That Changes Itself, and Ian McGilchrist, the author of The Master and His Emissary. I'm never going to look at the left and the right hemispheres of my brain the same way again.
I hope not.
Thanks to your lecture last night, and we look forward to seeing that actually in the first weekend of May on TVO's Big Ideas program. Thanks so much, everybody.
Support Ontario's public television. Donate at tvo.org.